So now we're getting into the injection portion of today's conference. And I don't have any financial disclosures or relationships with industry to disclose. But before we get started, how many people here are doing musculoskeletal injections currently? So show of hands. Okay. How many people here have had a problem as a result of doing an injection? So either a side effect or a failed injection. Show of hands. So who here hasn't had a problem or a failure with an injection? So everybody. Can anybody describe a problem they've had with an injection?
Didn't work.
How so? What happened?
Like they could have no response or like in terms of pain reduction or function or something. Just no effect.
Okay. Anybody else? Dave, you had a great one. Somebody that a follow-up of a patient that I had done an injection on. Do you remember this case? Yeah, yeah. No, this is good. This is important though, because when you go into the literature, there's like very few cases of adverse events described. And in fact, when you take a look at the literature in terms of reporting of side effects in larger studies, even that's limited. So what happened with the case that you saw on follow-up?
I saw him in the office. I can't remember how it was, a week or two after. I think you did a subacromial injection.
Yeah.
And he came in with some swelling and more pain. It was like suspicious for possible infection, but certainly not classic. Like there's no fever, much swelling, redness. And I think I called you that day.
You sure did, yeah.
Yeah, just to get the details because he wasn't very clear on it. And I can't remember where I went from there. I think I ordered a CBC and an ESR, and it was normal. I can't remember if I sent him to emerge or not. And I think he did fine. I think it was just like a reaction rather than an infection.
Yeah, and so there's a great example of you're not going to find anything like that in the literature, but this is something that can happen. So you can get, obviously localized pain, localized swelling if you don't inject in the right area. You can get swelling as a result of that. Anybody else have any other problems with injections?
I caught them. It was, I remember hearing about this case where one of our colleagues did a hip injection, and I guess, I can't remember what the timeline was now. I think it might have been at the follow-up, maybe the week later. The patient described sort of like, is this bruising normal? It was like significant bruising all throughout the thigh. And I guess when they scanned it again, it turned out to have created a pseudoaneurysm.
Wow.
And I think this was a case that was presented at CHASM, I guess, a couple of years ago. It was actually Graham Briscoe's case.
Did he publish it?
Yeah, well, at least he presented it as one of the cases at CHASM.
Yeah.
Hitting the vessel and creating something.
Well, there's another great one in the CHASM group. This is probably about 7 or 8 years ago. Somebody doing PRP. I'm not sure if it was ultrasound guided or not for hamstring, and asking the question about why somebody might get numbness and tingling down their leg afterwards. So the important piece that we're going to get into is understanding the anatomy of where you're injecting. So if we really want to do no harm, okay, that's probably one of the more important pieces. And we want to come up with a system to essentially reduce some of these side effects and how to troubleshoot if we run into difficulty. So anybody have an idea why you might get numbness or tingling down your leg from doing a PRP injection for a hamstring? What's right next to your hamstring?
Sciatic nerve.
Your sciatic nerve, yeah. So same way you can get a hematoma from a hamstring tear that can cause pressure on the sciatic nerve. The same thing can happen when you're doing injections. So so that's what we're going to try and do today, is come up with a little bit more of a standard process. and give you guys a model to work through so you can reduce a number of the problems that can occur during injection. So this is actually one of the few cases in the literature. This is from a physiatrist down in the States, and it was published in about 2005, I think, or 4. Oh, it's right there, 2005. And so this is a patient that came in with osteoarthritis of the knee, and they were getting a hyaluronic acid injection. And they describe a 21 gauge needle was inserted at the midpoint of the medial edge of the patella. The patient immediately complained of severe local pain. Okay, so on the picture here, this is from the article. Okay, this was the plane of the injection, which I've drawn in the red line, and this is once again the picture from the article. Can anybody identify a problem right off the bat with the pen landmarks? Now, I don't know if this was an error in terms of translation when they did the publication, but the top circle, what is that circling?
Apparently the patella.
Apparently the patella. Yeah, and the lower one, yeah, the lower one's supposed to be tibial tuberosity. So after this injection, patient immediately felt numbness in the infrapatellar area and the medial calf. There was no bruising, there was no redness at the injection site. And 3 weeks after, at follow-up, they had a sensory deficit down their leg on the medial aspect of the posterior calf. And this persisted for several months. In fact, at 9 months post, they still had this. What do you think happened? So I've just added on where the correct landmarking is. So it's just so you can see where the patella is and the joint line and the tibial tuberosity. And then I've added on where your saphenous nerve runs. Okay, so there are 2 superficial branches that run, and there's a number of anatomical variations. Okay, the authors interestingly postulated that they had a direct nerve injury, so the needle hit the nerve directly, and that's what caused the injury. I actually disagree. So keep in mind, they were using hyaluronic acid. If it injured the nerve directly, you would only expect that superficial branch to be affected. You wouldn't affect the rest of the nerve going down the leg to be affected. So I suspect what happened here, and we're going to talk about this, is actually a pressure-related injury. So they forced the hyaluronic acid into the nerve sheath, which went up and then caused the saphenous nerve injury. This is extremely rare. Okay, and in fact, some of the side effects we're going to talk about, they're not going to have any kind of long-term harm to the patient, but regardless of which, this is something we can still do better with a deeper understanding, both of anatomy, but also in terms of injection technique. So what can we do to improve safety? Okay, what are some questions you can ask yourself ahead of time to better prepare yourself, right? So what is it I'm going to do, and what is it I'm going to need? Okay, this is no different from if you're doing event coverage and you, instead of just essentially showing up at the event and then going out onto the field and realizing I might need some emergency equipment. Same thing from an injection perspective when you have a patient in the room. So there's things that you can do in terms of preparing yourself for the injection. You can do things in terms of preparing the equipment. And then a very important piece is actually preparing the patient. So who here uses mental preparation? Does anybody use mental preparation either at work or what do you do, Fahim?
Just kind of like, especially if it's a new procedure, I'll just kind of like either watch some videos first and then kind of like whenever I have some free time, I'll think about what I'm gonna need, what's gonna look like, and like what approach, how I want to position the patient.
Great. Anybody else use?
Yeah,
Nate?
I'll often, after I pull out my equipment, I'll just run through the procedure in my head and kind of follow along to make sure I have like every step of the way that I didn't forget, one.
If there is one thing I recommend from this talk is you guys should start using mental preparation in your regular practice. There's significant research to suggest that if you mentally and visually prepare for anything from like resuscitations to essentially even visualizing yourself working out, that you get essentially real benefits. And not just real benefits, when they looked at the data in terms of looking at resuscitations and visually preparing as opposed to actually physically doing a mock resuscitation, the people who did the visual resuscitation actually performed better. So actually visualizing what you're going to do with the injection ahead of time, what equipment you're going to need, that way you're not in the room and it's like, oh, I forgot an alcohol swab, or I forgot a gauze. And also it gives you that kind of, it's almost like it's like a practice swing in golf. You've essentially gone through a process that's just going to essentially limit any kind of potential misses. And the same thing, so you're going through what you need, what you're going to do, and what you're going to explain to the patient, including troubleshooting. Okay, so when we're talking about injection options from a sports medicine perspective, there's a number of different things we might be doing. We might be doing a diagnostic injection, a therapeutic injection. We might be aspirating a joint, so an arthrocentesis. Might be barbotage, which is to essentially break up a calcification in a joint. PRP, needle fenestration for tendonitis. So there's a number of different things we could be doing. The reason, once again, going back to the mental preparation, is you may go in to do a diagnostic injection, but you may then, after further inspection of the joint, say, well, I might actually want to aspirate something first. So that might change what syringe you want to have. You notice that there's a larger effusion that you initially expected. You might want a 50 cc syringe as opposed to the 5 cc syringe that you brought in for just the injection. So in terms of the injection materials, these are the things that you want to consider. Now, one of the things we can also improve from a patient comfort perspective is when you're drawing up medication, okay, is not to use the needle that you're going to use to inject, okay? Does anybody know why? It dulls. I don't have the image here, but there's a electron microscopy imagery of a needle used once, okay, so for one poke, and how blunt it becomes. So use a blunt to drop the medication. It improves patient comfort as opposed to using like your 25 gauge or your 22 gauge needle to drop either the cortisol or whatever you're using to, the local anesthetic you're using to inject. So kind of having an idea of what injection mirrors you want to have in time. For those of you in clinic, do you guys have trays already set up? Tim, do you have trays already set up? Wes, Andy? So that's something that can be utilized as well, is where you have like a basic tray that you can add stuff on. It just essentially takes one step off. And it's essentially, if you have the same tray each time, you can take a look, and if there's an empty spot, you know that there's something missing as well. Duong, welcome. Syringe selection. This is important. There's two things to want to keep in mind with the syringe. So one is making sure that you have used, there's not very many, sometimes if you have somebody else ordering the equipment for you, they might get a slip lock. A slip lock is a syringe that just has a straight knob that the needle slips over. And if you're injecting anything with pressure, that can come off. Generally, your hyaluronic acid already comes preloaded, so that's on a lure lock, and those lock in, so you want to lock in. And the second thing is, the smaller the plunger, the increased force you're going to need. So once again, more important with a hyaluronic acid, but just to keep in mind for what you're doing. Okay, obviously we want it to cause the less pain as possible. So if you can use like, a 27 gauge needle for a cortisone injection, great. If you're doing something thicker like a hyaluronic acid, we just talked about that case where there's possible pressure. You want to use a larger needle, and generally speaking, when we get into hyaluronic acid, you want to be using a 22 gauge because it's easier to push off, and you don't want. Sometimes one of the complications with hyaluronic acid is that if you, and I don't know if this has ever happened to any of you, but where initially, this definitely happened to many of us in the room when we were first doing it, is that we went to inject and the luer lock wasn't fully on, and you would lose some of the hyaluronic acid, it would explode out. So you don't want that to happen. That's why you want to use the luer lock, make sure that the needle is fully on, okay? And then the other one is the needle length, okay? So the other problem with the literature is that we don't really have a standard of where the injection's going in. So when you're taking a look at, randomized control trials, they don't really go into a lot of detail of how the injection was done in terms of landmarking location. But just in terms of, if you take even a look at this image here, if you're coming posteriorly and you have a bigger patient and you're using an 1.5 inch needle, you may only get up to here. So you may need actually a spinal needle to do a posterior glenohumeral injection on a larger athlete, like for example, a linebacker. Whereas if you're going anterior, it's a shorter distance. So patient preparation. So we heard from Wes, this is actually very, very common. So what causes vasovagal reactions? Any kind of noxious stimuli. So obviously, you can watch films, the sight of blood. That's definitely something you're going to come across if you're doing injections, but also the pain of the injections, a sharp poke. So one of the things that you can do for either shoulder injections, but more commonly knee injections, is have the patient lie down. Or if you want them somewhat sitting up, is have them lie back in the bed and sit the bed up so they have some support. That way you don't have to worry about them falling or dropping. Other thing, in terms of from a pain perspective, if you have an anxious patient, okay, I always advise that they turn their head away, okay? So they can't see what's going on. I'm going to describe what's going to happen, turn their head away, and don't let them see either the syringe or the needle. These are things that are going to be even more anxiety provoking, and they're going to heighten the pain sensation for the patient. And then the final piece is the landmarking, and this is the other take home today. So the landmarking, I've never had a patient say, I don't want you drawing on my shoulder or knee, okay? For the most part, actually, patients love it. Gives them confidence that you know the anatomy, okay, that you're dealing with, okay? But also gives you the confidence that when you walk out the room and get something and you come back, that you've already essentially assessed that joint and you know where you're going, as opposed to making a little spot and then the patient moves and it's a different location. So for the shoulder, okay, we're essentially landmarking all the bony elements in terms of around the shoulder joint. So we've got our acromioclavicular joint by landmarking the clavicle, the scapular spine, and the acromion. And so when we're landmarking, I generally draw a line over the clavicle, an outline over the clavicle, over the acromion, and down the spine, and then where the coracoid is, okay? What happens if we inject on this side of the coracoid? What's the concern? Lots of bad things. Yeah, neurovascular bundle. This is why you actually want to essentially palpate the coracoid on any patient you're doing a shoulder injection, okay, and landmark it. And now you know to stay on this side. Once you put that circle, you know you're going to stay on that side if you're doing a blind injection. Okay. From a posterior glenohumeral approach, is there any concerns if you're coming posteriorly? Anybody have any concerns about an injection coming posteriorly? Nobody? Yeah, it's pretty safe. You're essentially going through skin and then so some adipose tissue, and then you're going through muscle. So it's very safe. So if you're coming from posterior, you might come up against the bone. You might come across a anatomical variant of the scapular spine. Or if you're lower, you might come across the posterior aspect of the humerus, but you're not concerned about any kind of neurovascular bundle coming posteriorly. Okay, knee landmarking. Once again, so for the landmarking here, patellar tendon, joint line, okay? What are the concerns in terms of a knee injection? So let's start with on the right, anterolateral approach. So we're going into the knee from an anterolateral perspective.
If you choose superficial, you could just go into the quads.
Say that again, sorry?
If you choose superficial, oh, sorry, you said
So it's the anterolateral, we're going
Oh,
for this
never
one
mind.
here. So what if you're going along the joint line and you're quite low on the joint line? What might you go through? You might go through meniscus. That's going to be painful because you're going to go through the peripheral end of the meniscus. It's also, you don't want to be going through meniscus. You want to try and avoid that. What else might happen? So we talked about height. So if you go higher, what might you come across? Yeah, condyle or the notch, the trochlear notch. So you might come across that. So you're going to come across essentially hyaline cartilage. What happens if you go medial? Patellar tendon. Okay. Let's go with the anteromedial approach. We talked about the case, so it's a superficial saphenous nerve. And we're going to talk about troubleshooting this, but generally speaking, it's going to be same as anterolateral. So if you're going in and you're feeling hard resistance, that's going to be, so you come up and the needle stops. What are you up against? Bone. Okay. If you come up against something and you're like, I can kind of force the needle through, but it's going to take more pressure. Then what are you considering? What might you be going through? You might be going through cartilage, tendon, ligament. Now, the one tissue that you're not necessarily going to feel resistance with, which lies right behind that patellar tendon, is, what's that?
Fat.
The fat pad. Yeah, Hoffa's fat pad. So when we get to the injection thing, we'll talk about trajectory. But for the knee, essentially you're looking at the notch and you're actually trying to get into the notch. So you're going at an angle. So for your anterolateral or anteromedial, you're angling for the opposite condyle. So you're ending up inside the notch. For the suprapatellar, you're going straight across. So has anybody when you're doing injections, does anybody use supralateral? Okay. Are you aware of any problems with doing a supralateral?
Other than maybe hitting bone, not really. But so when I do those, it's usually I'll aspirate at the same time. So patient's got a big knee effusion. It's nice because you know exactly where you're going.
Yeah.
Most of the time I do an anterolateral approach.
So with these ones, yeah, there's essentially bone, there's quad tendon. There's not really much concern from a neurovascular perspective for any of these approaches, apart from that rare case. And like we have one case in literature about that medial superficial saphenous nerve branch, but these are all kind of safe injection spots. So when we talk about risks, this is kind of the common things we talk about. And when we talk about the side effects in cases, these are not necessarily things that come up. But so this is why we want to avoid any kind of area that has a neurovascular bundle, and that's why the landmarking is appropriate and important. Nerve damage, but as we saw, that's extremely rare, but it can happen. Does everybody know what a post-injection flare is? So if you're doing, for example, a cortisone injection, okay, some patients may get like a 48 to 72 hour period where they have like significant increase in pain, and then it kind of resolves. Are you going to expect that to occur with an infection in that period of time? So 48 to 72 hours? No, that'd be quite rare, like have an infection come on that quickly. That's usually delayed. So with the post-injection flare, you usually have patients take either like, Tylenol or Advil and ice it, and usually it settles down afterwards. We don't fully understand why they occur, and it's not necessarily harmful. Patients will often have relief after the fact. We talked about failure, obviously, and then obviously some local tissue issues. Corticosteroids, there's some kind of additional risks. There's a deleterious effect on the cartilage. Literature talks about a 2% post-injection flare rate. There's some skin changes. There's like white streaks or steroid chalks that you can get, and some depigmentation of the skin that can occur if the cortisol gets deposited in the skin, and dimpling as well. And then the other one, which came up in our chat group recently, is if you have a diabetic patient, it's very important to inform them that their blood sugars are going to elevate because you're giving a corticosteroid, and that can last for up to a week afterwards, but usually within the first 72 hours where it's worse. So especially if you have a patient that's on insulin, you definitely want to make them aware of that, because it's quite a profound effect. Okay, so how do we get to the pitfalls of injection? So not landmarking. So you've gone in, you've pressed on the joint. Okay, I'm going to inject here. You go out, you get your injection stuff. You come back in, the patient's moved. So they were sitting there like this, and now you come back in like this, and you go ahead and you do the injection. You're having difficulty. You come up against bone. So how are you going to troubleshoot that? Not mentally preparing, so you're not thinking about some of the other things that you might need in the room. Okay, the patient positioning is not optimal, so you have them sitting up for a knee injection, and as you go to turn a document, they go pale and they pass out. So these are things just in terms of that you can reduce. The other common one that comes up is anatomy. So larger patients or patients with significant osteoarthritis, you definitely want to be taking more time to do the landmarking part of the examination to reduce difficulty of the injection. So this is like the troubleshooting table we talked about already. Okay, so so patients anxious, what can we do? These are things we already talked about. So you want to essentially try and make them as comfortable as possible by showing them your confidence in what you're doing. So you're describing everything as you're going along. You're getting them to turn away from anything that might be scaring them. Okay, getting them to lie down. It's going to give them an increased ability to essentially relax. So the landmarking. So if you come up against something hard, you're checking your position. So just stop. The other thing is, once you start the injection, take your time. Okay, don't let your own anxiety mess up your injection. So if you're doing a shoulder injection and you're coming into the shoulder and you come up against something hard, stop, look at the angle, and this is all things we're going to be practicing this afternoon in the workshop so they can see. It's all about vectoring the needle appropriately to get it into the appropriate space. And with the models we have, it's translucent ballistics gel, so you can see where the needle's going and allow you to essentially get an idea of, oh, that's why I'm coming up against bone. So that's very important to be able to troubleshoot. And the other thing now, and that's what we're going to practice this afternoon as well, is, if you're still having difficulty, is consider using ultrasound to help guide your injection. The other one that I want to point out is, we talked about hyaluronic acid if it's difficult to inject, but sometimes you're in the wrong tissue. And that's kind of the take home from that first case that we saw. If you're trying to essentially inject cortisone or hyaluronic acid and it's under a lot of pressure, stop. Stop and reposition, because you're probably in the wrong space. And one of the things with the fat pad, you go into the fat pad doesn't give a lot of resistance when you're pressing the needle through. It will give you some resistance when you're pushing injectorate into it, and that can be extremely painful. The fat pad's probably the most sensitive part inside the knee. And so that's probably one of the commonest issues that you'll come across in a knee injection, why the patient's having pain during the injection. So listen to the patient. If the patient's having a lot of pain, consider repositioning the needle. This one here, I'm just going to show quickly. This is knee injection I did for instructional purposes. This is, we don't need the sound, but the interesting thing here is the patient came in, they wanted hyaluronic acid injections for both knees. And I actually had a failed injection on the other knee because I was, the patient was obviously consenting to this, but I was going to do an anteromedial approach. Now, based on anatomy, can you see that? You guys can't see that actually, just give me 1 second. Based on the anatomy, so if somebody has like patellofemoral OA, you might not have access to the anterolateral approach. And you'll see that when you examine them, the patella is shifting, is shifted lateral. So your anterolateral approach is going to be somewhat blocked. So then you should be going anteromedial or next to the patella. But let me just get this off here. No, give me 1 second here. Escape. There we go. And so you can see the preloaded syringe. This is a hyaluronic acid injection. Okay. There's no resistance in terms of the needle going in there. So we're above the joint line. So we're bypassing, we're going above where the anterolateral horn of the meniscus is. And you can see the angle. So we're going posterior, but we're going medial towards that medial epicondyle to go into the notch. Okay. And back here. Where are we here? So this is a knee injection. So we're talking about that superlateral injection. This is a case we just had 2 months ago. This is a patient had an MRI for a slightly different reason. This wasn't even commented on the MRI, the initial report. And this is the other theme of today is if your clinical examination is not in keeping with the radiology report, it's another reason why you should start to troubleshoot. So trust your clinical examination findings if you're finding something abnormal and the patient's still complaining of symptoms. So what we're taking a look at here is just posterior to the synovium and anterior to the femur. You're going to see really highlighted here, okay, is a cyst-like structure, okay? So this is a patient that had received a hyaluronic acid injection in the supralateral patellar location, okay? But the injection did not go into the joint. So if you don't get it in the right plane, you're going to get resistance, and this is actually essentially a ganglion cyst caused by a hyaluronic acid injection. This patient actually later had surgery and had that removed. But this just gives you an idea. This is not in the literature. These are things that happen. And so I would actually encourage you, at the very least, if you have an adverse event as a result of an injection, share it, okay? Because this is something that's important and helpful. The fact that we don't talk about, nobody wants to talk about their so-called bad injections. This is actually a problem because it's actually hindering our ability to get better.
Is that in the prefemoral fat pack?
Is it in the prefemoral? Yeah, it would be.
Did they, like, was the patient in a lot of, like, in the case, did they say they were in a lot of pain?
They had some pain there. They had some other issues. So they actually have a meniscal tear as well, but this wasn't commented on the ultrasound, on the MRI. I just happened to look at the images and then I sent them on to Dr. Bleakney, who then read it. This here, I unfortunately couldn't find the X-ray. This is another example, and this is why it's important. You will get referrals when you get out into practice, and for those of us in practice, and it's like, here's an ultrasound report. Here's a patient, they've got shoulder pain, they've got a rotator cuff tear, they've got a subchronal bursitis. Can you just do a cortisone injection? And as I was landmarking this lady, I felt a bump on her scapular spine. I stopped. I literally had drawn all over her shoulder. I stopped. I didn't do the injection, got an x-ray, and it turned out she actually had she had significant metastasis, including a lesion to the scapular spine. So this is once again, in terms of trusting your clinical examination, but also, not just going with something that's on a report, especially if it's different from what your examination or your findings are. Okay, so in summary, let's prepare ourselves for the injections better. Let's essentially try and mentally prepare ourselves. Let's get the equipment better prepared. And also there's things that you can do to help prepare the patient to make it easier for you when you're in the room, okay? Try and anticipate problems that might occur so that you are thinking about them ahead of time, and so that you kind of have an approach as to what to do when that comes up. And don't hesitate to landmark on patients. Like I said, patients, they actually love it when you're drawing on the joint. It gives them confidence that you know what you're doing. And these are just some of the references. Okay, anybody have any questions? Yeah.
So I've had a few times where I've had patients who are morbidly obese, like BMI 40 plus.
Yeah.
And for knee injections, really hard to landmark anything. And I've kind of just like flexed and extended them a lot until I feel fairly comfortable with where the joint line is. But do you have any recommendations for other techniques?
Yeah. So number one is especially when you're starting out, increase the amount of time you're doing the landmark examination. That's number one. Okay. Number two, if you don't have the confidence in terms of where your landmarking is, either because it's abnormal anatomy, like severely arthritic, or increased BMI, you're okay to say, I don't feel comfortable doing the injection at this point. But generally speaking, even with the obese patients, like you can feel, some with a BMI of like 80, you can still feel a patella. You have to press deep, but you can still feel it. Okay. Once you get the patella, okay, then you can essentially feel for the patellar tendon. Once again, you may have to press deep, but you can feel it. Same thing with joint line. You may have to go through that amount of tissue, but you should be able to feel it. It's kind of like, I always just say to residents, it's like you're trying to feel, picture a couch and somebody's put like a shower pole underneath the couch cushions, and you're trying to feel you're trying to feel the shower pole under the couch cushions. That's what you're doing with palpation. But absolutely, you should be confident after having done the landmark examination where those landmarks are. So for example, if I have somebody, I'm doing a shoulder injection, if I can't, for whatever reason, feel their coracoid, I'm not doing a blind anterior glenohumeral injection, right? So I think that's one of the things that are helpful in terms of positioning. So if you're doing an anterolateral intermedial, so having the leg over and in a flex position, usually anywhere from 90 to 70 degrees flexion. That allows essentially some of the tissue to come a little bit more taut and a little bit easier to examine. And then the other thing to keep in mind is usually with the obese patients, they'll have some arthritis. So once again, if the kneecap might be somewhat shifted to the left, so then if it's going lateral and we have less lateral space, go medial, or vice versa if it's more medial. Any other questions about either landmarking, knee or shoulder problems with injections? And once again, we're going to be practicing more of that. There's Dr. Bleakney, welcome. So guys, you want to take a chance to grab some coffee? There's refreshments at the back there.
Here, guys. Take a moment to do your evaluation when you have a chance. We'll get Dr. Clay